Dear colleagues, first of all, I would like to thank the organized committee for inviting me to this event. It's a great honor for me. As you know, the term sarcopenia is of Greek origin and associated with an increased fall risk and reduced physical strength. According to revised European consensus on definition and diagnosis of sarcopenia, is a progressive and generalized skeletal muscle disorder that is associated with increased likelihood of adverse outcomes, including falls, fractures, physical disability, and mortality. Sarcopenia has been officially recognized as a muscle disease in the International Classification of Diseases. The first studies in Ukraine were performed by ex-president of the Ukrainian Association of Osteoporosis, Vladislav Pavlosynuk, and the results of the studies were published in our monograph Sarcopenia in 2016. Sarcopenia mainly occurs in older individuals, but it can also develop in young adults. In clinical practice, two types of sarcopenia are typically recognized: primary and secondary sarcopenia. Primary sarcopenia is diagnosed when aging is the only apparent cause, whereas secondary sarcopenia occurs when there are identifiable contributing factors. These factors can include reduced physical activity, malnutrition, endocrine disorders, decreased production of anabolic hormones, neurodegenerative diseases, dysregulation of cytokine secretion, and the presence of inflammatory state and behavior. Secondary sarcopenia can be further divided into acute and chronic disease. Acute sarcopenia lasts for less than 6 months and is typically associated with a sudden illness or injury. In contrast, chronic sarcopenia persists for 6 months or longer and is often linked to ongoing progressive pathological conditions. Osteosarcopenia is mainly described syndrome that describes the coexistence of sarcopenia and osteoporosis, two chronic musculoskeletal conditions associated with aging. The prevalence of sarcopenia varies largely between studies and depends on definition used to define the disease. Prevalence of sarcopenia ranged from 5 to 17%. The frequency of sarcopenia in Ukrainian women aged 65 years and older is 21%. Sarcopenia's pathogenesis is multifactorial and consists from mitochondrial dysfunction, hormonal changes, declines in viral function, malnutrition, changes of gut microbiota with age, reduced cytolytic cell function, chronic inflammation, and lifestyle factors. There are many risk factors that affect bone and muscle, thereby relating osteosarcopenia. Sarcopenia diagnosis. SARC questionnaire is suggested by European consensus of definition and diagnosis of sarcopenia, and it's the most widely used screening test. We can use also SARC questionnaire. Remember, the sarcopenia is assessment questionnaire, and this year's screening tool. 26% Ukrainian women had a high risk of sarcopenia. The proportion of individuals with a high risk of sarcopenia increased with age. Various scientific groups, including the European Working Group of Sarcopenia in older people, the International Working Group on Sarcopenia, the Asian Working Group on Sarcopenia, the American Foundation for the National Institutes for Health and Sarcopenia Definition and Outcomes Consortium have published consensus papers outlining diverse definitions of sarcopenia. In conclusion, a low muscle mass is recommended as a diagnostic criterion for sarcopenia by all working groups, except for the Sarcopenia Definition and Outcomes Consortium. The lack of a simple standard diagnosis of sarcopenia has led to several issues. The Global Leadership Initiative in Sarcopenia was formed in an attempt to harmonize these competing definitions into one unifying common classification that would be used as gold standard in sarcopenia assessment. To create the full GLIS group, all members of current working groups were invited to join. The GLIS group conceptual definition of sarcopenia was published in 2024. It will now be used to develop an operational definition of sarcopenia for use in both clinical and research settings. According to the European Working Group of Sarcopenia in older people, the most useful consensus Muscle strength is a key indicator of sarcopenia, as it currently serves as most reliable measure of muscle function. Sarcopenia is probable when low muscle strength is observed. To confirm a diagnosis of sarcopenia, there must also be evidence of reduced muscle mass or quality. When low muscle strength, diminished muscle quantity or quality, and reduced physical performance are all present, sarcopenia is classified as severe. For assessment of skeletal muscle strength, we can use grip strength and chair strength test. For assessment of skeletal muscle mass or skeletal mass quality, dual X-ray, epitaxiometry, bioelectrical impedance analysis, QT or MRI. For assessment of physical performance rate speed, CPPP test, and other functional tests. There are cutoffs for the sarcopenia diagnosis, according to different working groups, especially a European working group of sarcopenia in older people and the Asia working group on sarcopenia. You can find and follow this slide. You can also find the algorithm for case finding and making diagnosis and quantifying severity in practice. Laboratory biomarkers for sarcopenia. Ratio of serum creatinine to cystatin C demonstrates moderate diagnostic accuracy and represents the most frequently utilized diagnostic biomarker for sarcopenia. The serum creatinine multiplied by cystatin C-based estimated glomerular filtration rate is potential diagnostic biomarker for sarcopenia. Inflammatory biomarkers constitute the predominant biomarkers and they exhibit general evaluation in sarcopenia patients. Among hormonal biomarkers, IGF-1 is particularly significant, especially for resistance training. Some metabolic and amino acids biomarkers were found to be lower in patients with sarcopenia than in the control group. Therapeutic strategies. We will talk about the role of exercise of sarcopenia, nutritional recommendations of sarcopenia, and pharmacological management of sarcopenia. It's known that resistance exercise 3 times a week over 12-24 weeks have shown to prevent loss of muscle mass in obese older people on calorie-restricted diet. Resistance training can significantly improve muscle strength and muscle quality in elderly patients with sarcopenia. Moderate intensity resistance training using tennessee bands may be the best training prescription for elderly patients with sarcopenia. Elastic band training, 40-60 minutes per session, more than 3 times per week for at least 12 weeks, was the most efficient training method. Body vibration for 6 months reduced rate of fall. Exercise intervention for 3-6 months improved knee extension strength, tongue and glow, and articular weakness. Combining exercise with other therapeutic interventions such as nutrition, supplementation, or pharmacological agents may provide synergistic benefits in promoting muscle regeneration and improving functional outcomes in sarcopenia. Adherence to exercise programs, however, can be challenging, especially for the individuals with limited mobility or other health conditions. The optimal combination of exercise with nutritional or pharmacological interventions also requires further investigation to identify the most effective approaches for different patients populations. Additionally, while exercise is a powerful tool for combating sarcopenia, it may not be sufficient for severe sarcopenia, which might require additional interventions. The nutritional recommendations of sarcopenia. Proper hydration is crucial for muscle function. All the adults are recommended to maintain adequate hydration with daily water intake guidelines set at 1.6 liter for women and 2.0 liter for men. Resistant training and supplements like creatine may help support muscle hydration. A well-balanced diet rich with high-quality proteins, vitamins, minerals, and healthy fats is fundamental in managing sarcopenia. The addition of specific supplements such as creatine, omega-3 fatty acids, leucine, and beta-hydroxybeta-methylbutyrate can help in reducing the risk and progression of sarcopenia. Moreover, Increasing the intake of antioxidants may help reduce inflammation, which is a key indicator in the development of sarcopenia. Recent studies indicate that the adherence to the Mediterranean diet can improve muscle strength and function, reducing the risk of developing sarcopenia. In clinical practice, optimizing nutrient flow through increased protein intake and the consumption of leucine-rich foods is key to improving muscle strength. It's known that intake of protein is associated with better lowering physical function and walking speed. Protein supplements in combination with resistance exercises improve lean mass and strength in older people when compared with resistance exercise alone. You can see how different amount of needed protein management sarcopenia according to last publications from 1.0 to 1.5 gram per kilogram per day. In patients with severe chronic kidney disease, it's usual to recommend a low protein intake from 0.6 to 0.8 gram per kilogram per day with sufficient energy intake. The optimal dose per meal of nutritional supplements you can find here. Consumption of our Ukrainian-developed hybrid meat product sausages in the diet significantly increases the amount of protein and amino acids of leucine, improves the functional ability of muscle, which is confirmed by the results of functional testing. Vitamin D. We know that the risk of sarcopenia was increased by 1.5-fold by lowering serum vitamin D by 10 nanogram per milliliter in women. The low vitamin D levels were associated with increased incidence of sarcopenia over 5 years. Randomized controlled studies confirmed significant increase of muscle strength on 25% in the vitamin D group. After 6 months of treatment, dynamic muscle strength improved significantly. Vitamin D supplements in older women improved muscle mass, strength, and physical function. Results of our Ukrainian study have shown that using individually targeted vitamin D therapy and a exercise program during 12 months significantly improves daily activity, muscle strength, quality of life, and reduce fall frequency in postmenopausal women. In conclusion, despite the long-standing availability of vitamin D supplements, there remains insufficient evidence with regards to the most appropriate dose, mode administration, and the duration of treatment on the functional outcome in older adults. There is growing evidence that physical activity, including exercise, can include beneficial changes in the qualitative and quantitative composition on the heart microbiota and metabolic function, leading to health benefits. These changes are independent of diet and may depend on the type and intensity of exercise. Some studies have shown that the heart microbiota is critical for energy metabolism, immunological response, oxidative stress, followed by muscle metabolism, and the regulation of the neuroendocrine system, which is significant for the physiological function of exercise. In terms of bacterial species that may positively impact muscle mass, oral beverage with lactobacillus or bifidobacterium longum increased with the muscle body weight ratio without affecting body weight. Experimental studies confirm that lactobacillus plantarum supplementation does dependently increase grip strength and endurance swimming. The number of type 1 fibs in gastrocnemius muscle significantly increased with lactobacillus plantarum treatment. We also observe the similar data after use of bifidobacterium longum. So prebiotic and probiotic supplementation offer additional benefits, but further research is needed to confirm the effectiveness in targeting muscle loss. Pharmacological management of sarcopenia. Testosterone. Testosterone in older men with decreased testosterone levels and muscle weakness can improve muscle mass, strength, and physical performance. Moreover, positive effects of testosterone on muscle strength have been reported in fertility dwelling pale older adults as well as healthy continuity dwelling older adults. owing to the fear of side effects like sleep apnea, thrombotic complications, and the increased risk of prostate cancer with testosterone treatment. Interesting research into selective androgen receptor modulators has advanced. Growth hormone. We know that low growth hormone levels contribute to a decrease in lean body mass and increase in adipose tissue. However, since then, it has failed to show a consistent benefit in improving muscle mass or function. Furthermore, there are various side effects to consider, including carpal tunnel syndrome, gynecomastia, joint and muscle pain, edema, and hyperglycemia. Similarly, there is limited data regarding the role of EGF-1 in sarcopenia. EGF-1 is also associated with multiple side effects. Another area of research focuses on the role of inflammation in the management of sarcopenia. Anti-inflammatory therapies, including the use of cytokine inhibitors and the non-steroidal anti-inflammatory drugs, have shown potential in enhancing muscle regeneration and reducing muscle loss associated with sarcopenia. Although significant side effects of NSAIDs in older adults, such as gastrointestinal and cardiovascular complications, pose a challenge for their widespread use in clinical practice. Anti-myostatin antibodies. In mice, anti-myostatin antibodies increased muscle mass and strength. In older adults with a history of fall, anti-myostatin antibodies increased the lean body mass and mildly improved functional measures associated with muscle strength. Clinical trials are ongoing to evaluate the efficacy and safety of myostatin inhibitors in older adults with sarcopenia. However, preliminary results indicate inconsistent benefits in improving muscle function and reducing the occurrence of physical frailty and disability. Irisine. The irisine has potential therapeutic effects for sarcopenia and may become a promising treatment for sarcopenia in the future. However, there is currently a lack of high-quality studies on the use of irisine in treating sarcopenia, and the relevant mechanisms of action are not yet clear. Stem cell therapy. Stem cell therapy is another promising approach for enhancing muscle regeneration. Recent clinical trials have shown promising results. However, further studies are needed to evaluate the safety and efficacy of leveraging stem cells for sarcopenia and physical frailty in humans. Use of antiresorptive agents in management of sarcopenia. Zoledronic acid. Retrospective study of the effect of zoledronic acid on muscle mass in osteoporosis patients shown the significant increase of skeletal muscle mass after 3 years treatment, while decreased in the control group. Denosumab. Results of freedom study observed that the group treated with denosumab experienced fewer falls compared with the untreated group. We also have the results of comparative studies of denosumab and bisphosphonates. One of them shown that denosumab had a significant effect on hand grip strength change and no significant effect on gait speed change compared to standard agents such as zoledronic acid, ebendronate, and alendronate. The appendicular limb mass was significantly higher in the denosumab group than the bisphosphonate group. Changes in appendicular limb mass with stronger related changes in lumbar spine bone mineral density. Other data confirm that only denosumab increased appendicular limb mass and hand grip strength in comparison with denosumab. In conclusion, denosumab displayed positive effects on balance function and fear of falling, which may underlie reductions in fall rates. Larger studies are warranted to clarify these effects and identify potential mechanisms. Teriparatide. Teriparatide improved bone mineral density, bone structure, bone strength, and the percentage of skeletal muscle mass, and decreased the percentage of fat mass and the adipose volume in the bone marrow. In conclusion, sarcopenia is a geriatric syndrome that is often observed in elderly and senile patients, reduces their physical abilities, affects the quality of life, and as a result, increases the incidence of falls and consequently the risk of osteoporotic fractures. In this regard, epidemiological studies on the prevalence and risk factors of sarcopenia in older age groups, the development of diagnostic methods, prevention, and treatment in this condition are needed. Adequate protein and calcium intake, maintaining sufficient vitamin D levels, and undertaking regular muscle and bone strengthening exercises are important non-pharmacological therapies for consideration by the treating clinician. Despite its clinical significance, there are no medicines used to treat sarcopenia by FDA approval in clinical practice. So future research should be directed toward pharmacological agents with therapeutic actions on both muscle and bone. Thank you for your attention.